Now we go on to our next session of lumbosacral blocks. For this session, may I please request Dr. Virendra Arya of Chandigarh to be our expert. Thank you. And our first speaker in this session is Dr. Sanjay Sinha. The topic is ultrasound and stimulating catheters in lumbosacral plexus blocks.
Okay, good afternoon. It's a pleasure again to be here in Pune. We've been having a great time with the monsoons coming down and the fresh breeze blowing. It feels so much nicer today. This afternoon I'll be speaking on ultrasound and stimulating catheter in lumbosacral plexus blocks. Again, I had presented this in the earlier slide in the earlier presentation that I had done, but just wanted to give you a snapshot of Horace Wells, who will introduce nitrous oxide clinically. These are some of the monuments that are in the city of Hartford, where I practice, and where Horace Wells started using nitrous oxide. The objectives of this lecture is to review the relevant anatomy of the lumbosacral plexus, and we'll be talking about the lumbar plexus and parasacral nerve blocks. I don't have videos for catheter techniques, but I'll be showing you single shot blocks for those techniques, and I will demonstrate, or I'll show you videos of a stimulating femoral catheter and a stimulating popliteal sciatic nerve block, of how we use ultrasound as well as the combination of stimulating catheters to put these blocks in place. So as you all know, the lower extremity is supplied by the lumbosacral plexus. The lumbar plexus gets formed by the ventral rami of L1 to L3, and the three major nerves that come out are the femoral nerve, the operator nerve, and the lateral femoral cutaneous nerve. And from the sacral plexus, which gets formed from the L4 to S3 nerve roots, the ventral rami, the sciatic nerve comes out. And if you can block the lumbar plexus and the sacral plexus, you can basically do any lower extremity surgery. The lumbar plexus, this is a patient in a prone position. The lumbar plexus, as I said, gets formed from L2 to L3 or L4. As the ventral rami, they come out, they actually join together and form this plexus in the substance of the psoas muscle. And that's why it's called the psoas block, or psoas compartment block. If you were to put an ultrasound machine in that area of the lumbar area, the image that you're going to get is which is sort of slightly, the transducer is placed 2 to 3 centimeters lateral to the midline. You'll start seeing the transverse processes and the shadows behind the bony transverse processes. And in between the transverse process, you'll see the psoas muscle, and it is in this muscle that the lumbar plexus sort of is getting formed. And if you were to drop a needle right into that space, you should be able to elicit a response. Usually you're looking for a quadriceps response, and when you inject your local anesthetic, you should be able to get a psoas compartment block. This is just another view. And this is a cross section of the lumbar plexus area. Here are the erector spinae muscles. This is the vertebrae of the lumbar vertebrae. This is the transverse process. Sorry, the spinous process. The transverse process is here. Here's the psoas compartment, and the nerves, they come out from the intervertebral foramen, and over here in the substance of the psoas muscle, they actually form the lumbar plexus. And essentially, to be able to do the block, you have to drive your needle right into the psoas muscle to get the lumbar plexus block. So here's a patient. We do it in a prone position, PSIS, and that's the line which intersects with the intercrystal line, and that's sort of approximately the area where we start our scanning and look for the transverse process, which is, you can see the hyperechoic areas and the shadows below that. It's a fairly deep block, so we generously infiltrate the whole area with a lot of local anesthetic solution. And as we advance our needle, this is a out of plane technique, so all you're going to see is tissue movement. You won't really be able to see the shaft of the needle. The needle is brought right into the lumbar plexus, and then we turn on a nerve stimulator. And what we're looking for is actually a quadriceps twitch. Once we get our twitch, we really don't try to optimize the current to a predetermined level. All we are looking for is the proper twitch. We inject our local anesthetic solution. Usually it's about 30 cc's of local anesthetic that we inject in this space of 0.5% ropivacaine or 0.5% marcaine to be able to get a block. So that's how you perform a single shot lumbar plexus block. Moving on, you know, the femoral nerve is another sort of major nerve that comes out from the lumbar plexus, and as it enters the thigh under the inguinal ligament, it is lateral to the femoral artery, to the femoral vessels. And again, for a single shot femoral nerve block, if you were to place your transducer in the femoral crease, you'll be able to clearly see the femoral artery and this teardrop-shaped structure, which is the femoral nerve. And to be able to perform a femoral nerve block, you bring your needle right next to the nerve and inject your local anesthetic solution, and you would have done a single shot femoral nerve block. One important concept to remember about the femoral nerve is that the femoral vessels and the femoral nerve, they are separated by the fascia iliaca. So for you to be able to get a successful femoral nerve block, you have to deposit your local under the fascia iliaca. And that is sort of a very important anatomical pearl that you should remember. So here's a patient who's having a femoral catheter. Prep and drape. The transducer is placed in a sleeve. We have unsterile gel on the inside of the sleeve, of the transducer sleeve, and so now you use sterile gel after that. When you're scanning, you see the femoral artery and the femoral nerve lateral to the femoral artery. We infiltrate, the transducer is placed in the inguinal crease, and we infiltrate fairly generously. It's a pretty big TUI needle that is going to go through that, travel through that space, so we infiltrate the trajectory of the needle very generously with local anesthetic. But you make sure that the infiltration of the local doesn't go close to the nerve, because if you block the nerve, then you won't be able to elicit a motor response when you're threading in a stimulating catheter. This is the infiltration that we perform. Here's the TUI needle, which is hooked up to a nerve stimulator. We set the current at 0.1 and then we don't touch it. We just leave the current at 0.1. As you insert it lateral to the nerve, you start getting the quadriceps response. You can see the classic patellar snap. Here's the TUI needle. As we bring it, it is an out-of-plane approach again, so you really don't, all you see is tissue movement, but it is brought lateral to the nerve, not at the nerve, but slightly lateral to the nerve. The stylet from the TUI needle is taken out, and then this catheter, which is hooked up to a stimulating, to the nerve stimulator, is then advanced. And as we advance it, the key is to be able to maintain the twitch as you advance your catheter. And we were able to successfully advance it. We usually advance it about 5 to 6 centimeters beyond the tip of the needle. And with the catheter in place, you have brisk quadriceps contractions. The TUI needle is then removed, leaving the catheter in place. That's the stylet of the catheter that is taken out. We tunnel all our catheters, and so they're tunneled about 3 to 4 centimeters under the skin. Once it's tunneled, you can re-stimulate it, and as you inject your local anesthetic, you'll abolish the contraction with minimal injection of your local anesthetic solution. And as we inject the local anesthetic, the contractions disappear. and you can actually see the spread of the local right on top of the nerve. As you can see that area of darkness or hypoechoic area as the local anesthetic surrounds the femoral nerve. The femoral nerve is right there. We usually will inject 15 cc's or so of local anesthetic for the initial bolus. The catheter is then taped with the steri-strips and tegaderm, and these catheters usually remain in place for approximately 2 days, 2 to 3 days, usually 2 days for our total knee replacement patients. We usually will run an infusion of ropivacaine 0.2% at 6 cc's an hour for 48 hours. Let's move on to the sciatic nerve, which is an output of the sacral plexus. It can be blocked in the parasacral area, the classic Lumbar's approach, infragluteal parabiceps approach, mid-thigh, and the popliteal fossa. I'll show you a video of how we do the parasacral blocks. The parasacral block is actually performed as the sciatic nerve just comes out from the inside of the pelvis into the greater sciatic notch, and it's in that area that we perform the parasacral. So it's a block that is sort of performed very close to where the sciatic nerve gets formed. We do it with a combination of ultrasound and nerve stimulation. The important things to remember is that the inferior gluteal artery is medial right there in that area, and there's nothing in the back of this nerve. So you have the pelvic structures that are in the back. So if your needle sort of goes beyond the nerve, you can actually injure the pelvic structures like the rectum, the colon, and those kind of bladder. So you have to be very precise and be able to visualize your needle and the nerve very precisely. So here's a patient in lateral position. Again, very generous infiltration. It's a fairly deep block. And here's the posterior border of the ischium. The sciatic nerve is right there. You can actually see the pulsations of the inferior gluteal artery there. There's the needle coming in. And as we bring the needle close to the nerve, we turn on our nerve stimulator and we get a twitch. Tibial nerve component of the sciatic nerve is getting twitched. You can see the gastrocs contracting. And as you can see, it's a fairly deep block. This is a fairly big patient as well. And as we inject our local anesthetic, you can see the spread of the local on top of the nerve. You really don't have to move the nerve at all, the needle at all. That's the PSIS if you were to do it, surface landmark based technique, the ischial tuberosity. And if you were to draw a line connecting those 2 points, about 6 centimeters from the PSIS, that's where where you would insert your needle if you were doing it landmark based technique. And we are sort of pretty close to where we would have done it, correlates pretty close to what we have done with our surface landmark. The other approach to the sciatic would be in the infragluteal area between the greater trochanter and the ischial tuberosity. That's where the probe would be put. The biceps muscle is here, and you have that groove, and right in that groove you can actually block the sciatic nerve. You can actually visualize the nerve under the muscles, and again it's a very simple block. You bring your needle right next to the nerve and inject your local anesthetic solution and do it. In the popliteal fossa, you can see the sciatic nerve as it sort of comes down the popliteal fossa. It then divides into its 2 components, the posterior tibial and the common peroneal. And you can visualize the nerve above its bifurcation, at the level of bifurcation, and below the bifurcation, and block the nerves, either the components individually or at the bifurcation, which is sort of the modern, the newer way of doing it to get a faster onset block or to block it more proximally. Again, Again, you're going to see the nerve as a hyperechoic structure. you bring your needle right next to the nerve and you inject your local anesthetic solution. So here's a patient where we're putting in a popliteal nerve catheter. She's going to have some kind of a complex foot and ankle procedure. So instead of doing it in plane, in a cross-sectional view, we'll turn our probe so that you can actually see the long axis of the nerve. So here's the nerve, and as we turn our probe, you'll see how as we have slowly turned our probe, and that's basically, so the probe is now alongside parallel to the nerve and on the long axis, and we decided to do the block in that sort of fashion. It can be done in a transverse scanning method as well. There's the local going in. The TUI needle. Make sure that the foot of the bed is beyond the edge so you can see the contractions. Here's the needle approaching the nerve. And as we get right next to the nerve, we see the twitches, we elicit a motor response, which is again a tibial component of the sciatic nerve. The stimulating catheter is then hooked up to the stimulating box and advance, and as we advance it, the key is to be able to maintain the twitch as it's advanced. We then remove the needle, and as we inject our local anesthetic solution, you can actually see the spread of the local on top of the nerve. As we inject the volume, it sort of, you can see the spread and also a little bit of the catheter come into view as the local is injected. The catheter is then tunneled, and then we tape it on the lateral side. We take the hub on the lateral side. Thank you.